Hello, everyone, and welcome to the Connect Experts Update on the SOGC Clinical Practice Guideline number 441 on antenatal fetal health surveillance. I'm Chris Rokosh, and today my guest is Dr. Sharon Dore. Many of you will remember her from the August 2020 webinar that we did on intrapartum fetal health surveillance. She is one of the principal authors of both guidelines, so the absolute best possible resource to bring this information to us today. First of all, a quick thanks to all of you for being here. I'm so grateful that you took the time to join us and learn and share in this with us. We have attendees from Vancouver to Halifax with an interesting mix of plaintiff and defense lawyers, obstetricians, nurses, nurse practitioners, and midwives. It's just an impressive wealth of knowledge and experience joining us today. So welcome to every single one of you. Hopefully everyone received a copy of the guideline number 441 by email in the past week, or maybe first thing this morning if you just registered. If you didn't get one for any reason, we can quickly send you one right now. Just email Erin at connectmlx.com, and she's standing by to help you out. A couple of very brief notes before we start. Today's webinar will be 60 minutes long. We're going to have a 45-minute presentation ending with a 10 to 15-minute Q&A. Your audio has been disabled, but we'd sure love to hear your questions, so please submit them in writing by using the Q&A button. And throughout the webinar, send your questions whenever they come to mind, because we'll just answer them at the end, and I'll have a look. I'll have a look and read them. We'll answer as many as we can at the end. If you're having any technical issues, trouble with audio or video, again, we have tech support standing by, so send us a quick note in the Q&A and we'll help you out. A recorded version of this webinar will be available in about a week on the connectexperts.com website, which is connectmlx.com. And as always, you can claim continuing ed or professional development for the webinar that you're attending today. The primary goals of the guideline we're going to review are to provide reassurance of fetal well-being and normal fetal oxygenation before the onset of labor, and to identify potential hypoxia during the antenatal period, allowing for time for interventions to reduce adverse outcomes. There are recommendations for change in this guideline around the assessment of fundal height, assessment of fetal movement, the measurement of amniotic fluid, and the use of fetal health surveillance modalities. Changes that can affect the nursing and medical standards of care, as well as the expert analysis of medical legal matters. It's important stuff. So let's get after it this morning. Our speaker today, Dr. Sharon Dore, is a perinatal advanced practice nurse at Hamilton Health Sciences Center. She has responsibilities for clinical and inpatient complex perinatal care. She's an associate clinical professor at McMaster University School of the Department of OBGYN. She's had leadership roles in the Canadian Association of Perinatal and Women's Health Nurses, the American Associations of Women Health, Obstetrical, and Neonatal Nurses. She's a member of the Education Innovation Committee of the SOGC, the Canadian Advanced Practice Nurses Association, the Ontario Maternal Newborn Coroners Committee. She's a frequent alarm course instructor, which is advances in labor and risk management. And in addition to her work on the fetal health surveillance guidelines, she's currently working on an update to the SOG labor support guidelines. Sharon Dore holds a PhD in nursing. Sorry, I lost my page there. She holds a PhD in nursing from Wayne University in Detroit, a master's in education from Brock University, a nursing baccalaureate from McMaster. She's here to tell us everything she knows about this guideline today, so let's get started. Welcome, Sharon. The stage is all yours.
Thank you very much, Chris. I'm just going to share my screen. And here we go. Now, as I mentioned, I'm going to be talking about antenatal fetal health surveillance. And in the context of this, we're going to have some objectives looking at the latest evidence and importance of antenatal assessment testing, looking at terminology that people use, because sometimes people continue to be a little sloppy and lazy and a bit glib in some of the terminology, which can be confusing, and you identify the appropriate use and timing of testing and assessments that are going on. So within that context, I just want to say that one of the things with this guideline, it was developed by a national group of caregivers. So you can see people from different geographic areas. Sapina Sharma is a maternal fetal medicine who I work with at McMaster. But otherwise, people are from all over the country, as well as the opportunity was given for review by several committees, which included family physician, advisory, and obstetrical content committees, and guideline management. So a lot of eyes went on this guideline before it was published, including approval by the board of SOGC. Some cautions when we start this. First of all, while all of this is founded on basic principles of science and fetal physiology, there is very limited high-quality evidence that relates to how to assess, when to assess, how often do you assess, and how important is it. This is no different than some of the evidence that we have around interpartum fetal health surveillance. We just do not have those really high quality randomized controlled trials because so much of it is embedded in our clinical practice. We can't make something into a randomized trial and deny it to 50% of the participants. The other caution to think about, the fetus isn't there talking to us directly. As you all know, we're going through some barriers of tissue to try and say what's going on in there. So we use palpation, we use fetal movements, we look at heart rate patterns, and we use ultrasound. So all things that we assess that fetus with are done indirectly, not with direct visibility of the fetus, although ultrasound's getting better and better at that. So when we think about all of this, what we really want to do is choose wisely. And what I mean by that is use antenatal assessments based on best evidence and not use unnecessary testing or inaccurate testing that makes inappropriate use of resources, uses up things that we need to have available to us for more important things. So one of the things, if we can think wisely about what we're choosing for tests, will decrease patient anxiety because patient says, I'm getting a test. Oh my goodness, what's wrong? And we also will have our resources available to us for appropriate use. And testing when we're thinking about this, we want to think about when is it really necessary? What happens? If you do an unnecessary test, you're going to have a cascade of events with more testing and more patient anxiety and likely more interventions. We all know the likelihood of cesarean section rates can increase when people have concerning test results. So what is the real goal of antenatal fetal health surveillance? The real goal is to assess and reassure yourself about fetal well-being when you're in an at-risk situation, and also to identify potential fetal decompensation that may be going on so you can intervene appropriately. Fetal decompensation really means concerns with oxygenation of that fetus or fetal hypoxia. And that kind of decompensation can be an acute event or can be a chronic event. So let's talk for a minute about hypoxia. Short-term hypoxia is tolerated well by a fetus who's got good oxygen reserves. So oxygen reserves are a surplus of oxygen that are maintained by that fetal placental unit. The way I kind of describe this is if you have short-term hypoxia, it's like diving underwater in a swimming pool. And I know we're coming up to winter, but pretend you're going swimming. And you take several good deep breaths and you dive underwater and you have a period where you aren't getting oxygen in, but you have oxygen reserves that you call upon while you're underwater. So you get to the end of your swim and you're doing okay. So that is sort of the analogy to what those fetal oxygen reserves will do for the fetus. You can also have impaired gas exchange that if it's just sort of brief, what will happen is you may develop bradycardia in the fetus, and that's because the fetus, being very smart with its adaptive mechanism, says, I'm going to slow my heart rate down because that way I will fill my ventricles and I will push out more blood with each beat of the heart and circulate my oxygen efficiently. The other mechanism that the fetus uses is increasing the heart rate. So the fetus rapidly circulates the oxygen it has available to it by increasing the heart rate. On a more chronic basis, you can see a change in the fetus's blood flow to vital organs. This is often known as well as brain sparing, where the blood flow changes, therefore the physiology of where the blood is going and the actual physical appearance of the fetus may change. So the fetus prioritizes blood flow to brain and heart and adrenals, but decreases blood flow to, for example, the GI tract. So it depends whether that gas exchange limitation is chronic or acute. And this is a kind of look at what happens when the fetal decompensation occurs. It has a particular and predictable change in fetal status. So you can see at the top, the fetus is well and not at risk. And then as deterioration begins, you go down this left-hand column and the fetus becomes increasingly more concerning to the point at the bottom where we're looking at stillbirth or asphyxia occurring. So while those steps are predictable, what is not predictable is the speed at which that occurs. It varies depending on the risk factors that the fetus has in situ. It depends on gestational age, all sorts of different things. So our goal, while we look at this graph, is to say, where is that fetus at in this entire picture? And therefore, what interventions might we need to make based on that fetal status? So let's talk a little bit about oxygen for a minute. It's vital to fetal well-being. And normally, as you well know, there's a arrow that is a whole cascade of oxygen that occurs. So it starts off in the environment, goes through the pregnant person's lungs, through their vascular system, through the uterus, placenta, and cord, to the point it goes down to the fetus. And in fact, we have adequate fetal oxygenation and oxygen reserves, which is great. However, if at any point there's an obstruction to any one of these steps, and now I've got red crosses for all of them, but it can be just one or it can be for many. What happens then is we have a change in what the pathway becomes. The fetus starts to use their oxygen reserves up. It makes use of adaptive mechanisms that are available. And if those become used up, then we go on a different pathway. And that pathway takes us to hypoxemia, hypoxia, metabolic acidosis, and hypotension. So what you want to do is find out where on this flow that fetus is so you can intervene appropriately before untoward events occur. Now, I'd love to tell you there's a perfect test, and you can just do this test and you'll know exactly where things are at. Unfortunately, that's not true. There is no ideal test. There are many tests we consider. There are tests that we take on throughout pregnancy. There are tests we take on to look at the fetal heart rate patterns, to try and detect where things are going acutely. And there's also ultrasound, which is increasingly developing expertise and technology to allow us to do that more and more. And within ultrasound or sonography, we've got all sorts of different tests that we can consider and look at. So when you think about what am I going to do, you think about how and when to test and what to use. So overall, when you look at that, you're going to want to say, I want to know if there are risk factors for fetal oxygenation. That's going to drive my testing decisions. So what are my risk factors and what are my resources that I have available to do the testing? As with all cases, This should be shared decision-making with the pregnant person, that they have an understanding of their risk factors, and you have an open and clear discussion with them about what you're going to be doing and why you're going to be doing it. Looking at risk factors is a dynamic process. It should be ongoing, and it may change during the course of pregnancy, which means that discussion with the pregnant person has to reoccur over and over again. And when you do have some plan sorted out, make sure you document that plan of care in your antenatal records so that it's clear to everyone what your plan is, what you're doing, and where you're going. And you always consider in all of this, what are the total clinical pictures? Risk factors are obvious, but also thinking about local resources and protocols. Where are you? What is available? Do I need to transfer this person to another facility in order to get that work done? Do I need some detailed ultrasonography such that is not available in my center, but may be available down the road? How do I plan for that? How do I discuss that with the pregnant person so we're all on the same wavelength? What is the urgency, which is always a factor? Does the patient even agree to it? There are many individuals, certainly in our community, who say, I really don't want an ultrasound. That is their right to make that decision after they've had a very clear explanation, an informed discussion, and shared decision making. And often when we think about testing, remember the non-stress test, the biophysical profile, and Doppler sonography are used best when there's only a risk of decompensation. It's not something you need to do to have reassurance in what is a typically healthy situation. That is unnecessary testing. And the other thing you always remember when you do any of the antenatal testing, it assesses the fetus at that one point in time. It does not necessarily have any predictive value for how that fetus is going to be a week from now. So you have your result of your test, and that's what it is right now. So let's talk a little bit about some very specific tests and what they mean. The one we all talk about, fetal movement counting. It's the one that's easy. There's no cost to it. There's no technology. Can be done regularly. Most patients really quite like doing fetal movement counting. And there's some concrete criteria there. Most importantly to some people, you can go on Google and it's all there. So yeah, it's real because it's on Google. Dr. Google says so, must be right. Anyhow, that's just my sarcastic comment for today. The limitations, though, of fetal movement counting. There are many, many, many things that influence fetal movements. Gestation, the activity of both the fetus and the patient. Where's the placenta? What's the patient general body habitus? What about multiples? How does that affect fetal movement counting? And the maximum period of fetal movement counting felt by the patient is usually around 28 to 34 weeks. And as you get closer and closer to term, the change in the movements are occurring because that fetus is getting bigger. There's less fluid to body space to run around and do swan dives and other kinds of creative activities in utero. So it's just, you get slower and more powerful movements. And one study that was done looked at over 70,000 women, and they found that patients at term only feel about 40% of the movements. And that's because of the changing nature of the movements as gestation advances. And reduced fetal movement, or RFM, may be associated with hypoxia, but less clearly associated with stillbirth unless it's repeated. It's always a red flag for us. And interestingly, many of us have a protocol, whether it's a count to 10 protocol that was from the UK or 6 movements in 2 hours. We have some sort of counting criteria whereby we say, okay, if it's not that, then it's reduced fetal movements. Internationally, people are moving away from counting. They're saying pay more attention to what that woman feels or that pregnant person feels is going on with those movements. So the bottom line on fetal movement counting is all pregnant individuals should regularly monitor their fetal movements from about 26 weeks gestation. And they pick 26 merely because that's when they are more consistent and more likely to be regularly felt. Ensuring that the person knows that those fetal movements will change with advancing gestation. That doesn't mean to ignore it, but just awareness that that's going to happen. And that they should present immediately, and emphasis on the word immediately, for assessment of reduced fetal movements, regardless of the technique used. And by that I mean it's not necessarily a counting technique, but I just feel this baby isn't moving as much. It doesn't feel right. I did all the right things. I laid down and I tried to stay focused, but this baby was just not moving as much. And in those instances, women or pregnant people are encouraged to present for further assessment. Now, what about prenatal visits as another method of assessment that we use? Usually it's face-to-face. Sometimes it's virtual. That's particularly true if there's distances or weather involved, particularly if you're trying to approach a specialist. And often there is shared care with a specialist, or shared care between family physicians and midwives, or with an obstetrician. It all kind of varies a little bit. And one of the things to think about is if you do shared care, it's important to clarify what is the role of that other caregiver. In other words, if they're going to a diabetic clinic, you may say that diabetic clinic is looking after their sugars and their insulin levels. That's fine. But what is the role of other caregivers? So we're very clear on who's on first and who's on second and who's doing what. And the other thing is, how frequently do you have a prenatal visit? Remember that we have kind of a baseline that we kind of all have a mathematical formula for so often early in pregnancy, then it goes to every 2 weeks and then every week. What's that based on? Well, sometimes it's based on billings. Sometimes it's based on historical practices. But what things will change that? I know from working in a high-risk clinic, obviously perinatal risk factors are one of the most frequent causes of increasing that particular frequency of visits. But there's also social determinants of health that are factors, as well as what about that anxious patient? What about that very anxious individual having their first pregnancy? Are they in need of more visits for all sorts of reasons and reassurance and making them positive about that pregnancy than the person who's a gravida 4? Maybe, maybe not, but it just says there's an opportunity to individualize the frequency of those visits. And what do you do when they come in for a visit? Well, at every visit, we probably ask about signs and symptoms. We always do a blood pressure. We'll always do a risk assessment and see if anything new has developed or any other concerns exist. We'll listen to the fetal heart tones. We aren't doing a proper full assessment. We're saying, is there a fetal heart? We're looking at viability. And we'll do uterine size, either with a measurement by cephalofundal height or by palpation. And then we're going to consider and always consider the need for discussion and education, questions, plan of care. And at every visit, do you actually need to do weight, urine and sugars, proteins? Maybe not. So think about, from a choosing wisely standpoint, which of those are required in your particular patient situation. And as always, you document your defining findings, particularly your discussions and your plan of care. So you need to think about, does your particular EMR or your provincial form have the spots and the space for this discussion? I think it's always very challenging. I see sometimes the third carbon on some of these, and I cannot make out anything that's written on it because it's squeezed in so tightly. So think about, is there a narrative form for some of the discussion about education and plans of care that make it better? Is the patient carrying a copy of it for their availability in case they turn up at another site other than where they are expected to deliver? And so making sure that that form meets your needs and allows you to write down what you need in order to complete a full assessment of that fetus. In Ontario, I know that PCMCH is changing our antenatal form, and that happens periodically in a variety of centers. Now, what about looking at fetal growth restriction? I mean, it can be detected by abdominal palpation with experienced hands. You all get very accustomed to saying how much fluid is there and how big does that baby feel, or by actual direct measurement of the cephalofundal height. And that measurement is often done with a tape measure with numbers on it. It's always interesting to think about doing it with a blank piece of paper, and therefore you aren't always correlating it to what the gestational age is. You do that afterwards once you've indicated how big it is. We did that once with our residents. It was quite fun to see how accurate and how similar those results were among different people. One of the things that we've been able to determine is we've looked at a group called Intergrowth. And if you're not familiar with this is a group of about 300 researchers in 27 institutions in 18 countries that come out with all sorts of information coordinated out of Oxford in the UK. And they looked at 60,000 women and determined the fundal height is considered abnormally low if it's greater than or equal to 3 centimeters behind gestational age. So if we think about that kind of criteria, that's very appropriate. And there is an SOGC guideline out that looks at fetal growth restriction versus small for gestational age, recently published. And if you want more information, I will refer you to that. So when do people have to come in for extra visits beyond whatever you've determined relates to their prenatal visit schedule? Basically, anytime they are worried, and it can be nonspecific. There's a tremendous emphasis on focusing on patient perception. Am I concerned? Am I worried? You have the right to come into triage if you're worried, and that's okay. I know sometimes when we get really busy in there, that can be a bit frustrating, but it's very important that we ensure that individuals have open access when they are worried. They can certainly call their care provider or come into triage or go into a clinic, but having some access to responsiveness when they are worried. They should come in as well, obviously, any perception of reduced fetal movements, regardless of a count number. And part of that is teaching what is a fetal movement and how fetal movements change with gestation, as we've already mentioned. And obviously, any unexpected risk factors mean that they need to come in. Bleeding occurring, a trauma, a slip and fall. We're coming into the ice age of our seasons, and lots of that may happen. Preterm labor possibilities, all of those things, when they're worried or those things occur, they need to come in for further assessment. So talking about some tests after that, let's talk specifically about a non-stress test. A non-stress test is used with low-risk individuals who've presented with that trauma, bleeding, or reduced fetal movements. It's used in high-risk individuals requiring frequent surveillance. Usually they think about greater than 32 weeks for that, for most at-risk patients, but if there's an acute event or fetal growth restriction, that may occur prior to 32 weeks, and you may even be thinking of doing a delivery if there are concerning events. How to use it? I'm sure most people are fairly familiar, but just in summary, making sure the individual empties their bladder and is comfortable in a left lateral position or semi-Fowler's position. Position the toco and transducer so you have an interpretable tracing without gaps. Make sure you verify the patient heart rate and separate that from the fetal heart rate as you do with intrapartum fetal health surveillance, so we don't have the artifact of picking up a maternal heart rate. If they're going to use the fetal movement counter, make sure they know how to do that. You're doing this for a minimum of 20 minutes, maximum 80 minutes. You're going to classify and determine the plan of care and document this on a standardized form that includes all the elements you should be assessing. Now, one of the things that I want to emphasize is this is a non-stress test. So if it's a non-stress test, it means no contractions, because contractions are a stressor for the fetus. Apologies for the phone ringing. And when you do that, you confirm the frequency and intensity. If you think you have any contractions showing up or uterine activity, you use manual palpation to determine intensity and frequency, asking the patient what they're experiencing, because maybe you're seeing something showing up and they have no idea. They're sitting there playing cards, having a good time. It doesn't even bother them. And what shows up on your pressure-sensitive device, such as the tocodynamometer. And if contractions are present, you then are assessing that fetal heart rate using intrapartum fetal health surveillance criteria and determining their labor status. I really want to emphasize this point about uterine activity and contractions. I see many people inappropriately using the term NST. So what you really want to be sure is that no one, when someone's coming in for early labor assessment when there's contractions, calls it an NST. It is not. That is something totally different. That is when you're doing fetal heart rate surveillance in the presence of uterine activity. So an NST means no contractions generally. This is a chart of how to classify the NST as normal, atypical, or abnormal. And I'm not going to go through all the bits and pieces. It's all in the guideline. A couple of things I do want to point out, though, that if in fact, and it's right at the bottom, it's kind of blocked out. Oops, my apologies. Blocked out by a number of Zoom bars here. But basically, if you have the three items with the double red stars on them, you can only assess that if in fact you have contractions, because it represents the appearance of contractions, and you can only identify early or late decelerations in the presence of contractions. So you would never see those in a true NST that is done without contractions. Basically, the actions associated with this is if you have a normal one, if there's reduced fetal movement, what else is going on? Give some further assessment. Do you need any further assessment at all? In an atypical classification of an NST, you still need further assessment. Review the clinical picture in total. Continue with the fetal monitoring so you know what is going on. You may need to move to some additional testing, such as sonography or something like that, depending on the circumstances and the risks presenting, and you may consider admission to hospital. If it is abnormal, again, urgent review of the clinical picture, possibly ultrasound, further assessment, possibly admission, possibly delivery to consider. This flow chart, again, is in the guideline, and it's taken from the guideline, and you can probably read it more easily in the guideline than up here on this slide. But basically, it says when you have people coming in with reduced concerning information, you want them, they've got reduced fetal movements, you want to do an NST and detailed assessment of risk factors. If you have a normal NST and no risk factors, let somebody know, continue with prenatal care, antenatal care, and repeat if concerns persist. But if you have a normal NST with risk factors present or clinical suspicion of fetal growth restriction or oligo, That's when the primary care provider must need to be informed, may consider ultrasound as soon as possible, review fetal growth, and all sorts of other tests. If it's atypical or abnormal, you're admitting that person to hospital for additional assessment and surveillance. And in all of this, you're going to determine where you're going to go in the long run based on the NST, the ultrasound or sonography findings, gestational age, and the overall clinical picture that you have to look at. Are you going to deliver this person right away? Are you going to sit on it for 24 hours? Are you going to repeat the test? It all depends on the variable risk factors that the individual presents with. There was a test that people did quite rigorously a number of years ago called the contraction stress test, and I understand it's still being done in some centers. And this is where people look at generating 3 uterine contractions within a 10-minute period, and those may be spontaneous or induced, and then they classify it based on presence of late decelerations. Now, it is less frequently used. It is something that really represents when you're starting an induction of labor. That really is more like the contraction stress test to see how tolerant is that fetus of that additional stress of contractions. And often when people are doing that, they need to consider the availability of cesarean section services, because if in fact they are concerned and worried and they further stress this fetus, it may be an indication to move to cesarean section. What about ultrasound? I've mentioned it. We know point of care ultrasound is certainly rampant and available. The cost of that equipment is going down and down, and there's a little butterfly you can plug into your phone and do very quickly. Now, it really does provide you with real-time observation. You can look at assessment of fetal vascular physiology, but not necessarily with point of care. You may need a real consultant ultrasound to look at that. You're going to look at amniotic fluid volume, fetal growth, and possibly consider a biophysical. Again, all of these may not be available using your point of care device, depending on the sophistication of that particular piece of equipment. However, with ultrasonography, always remember, we lack the randomized controlled evidence. It's so embedded in our clinical practice. We aren't randomizing people to different kinds of routines. There's limited cost effectiveness studies, and there is a fair amount of variation in actual clinical practice based on when people initiate it, what gestational age, how often they do it, and what was the indication to actually do it in the first place. What can it give us? Well, as I mentioned, it can give you amniotic fluid volume. And one of the things to think about when you think about amniotic fluid volume is, when do you call it oligo or polyhydramnios? So too little or too much fluid. And these are criteria that have been developed based on best evidence available to look at single deepest pocket for both of them as the criteria to determine oligo or polyhydramnios. You may use sonography for a biophysical profile, for growth, and I will tell you that there's a recent clinical practice guideline on ultrasound, 2021, looking at fetal growth, and I refer you to that if you want more information on fetal growth restriction and small for gestational age. We also will use it for Doppler assessment of circulation, particularly looking at umbilical arteries, and again, looking at twins or other twin or multiple situations. And again, there was a clinical practice guideline number 440 in August of 2023 that came out talking about that with respect to multiple fetal gestations. So I refer you to that for more information. So let's talk a little bit about this biophysical profile that people are very popular in using. So there are 5 components to it: breathing movements, body movements or limb movements, tone, amniotic fluid volume, and NST. The 2 most important components of those 5 are amniotic fluid volume, because amniotic fluid volume gives you that chronic adaptive mechanism that the fetus is using. It's recirculating its blood flow to urgent areas and taking it away from areas that may relate to fetal well-being, less important for fetal well-being. You also have an NST, and the NST is important because it's dealing with acute fetal well-being. Breathing patterns are also interesting because breathing patterns can be variable as to how they occur and what their appearance is like. If we look at perinatal mortality within a week by biophysical profile, and this is not brand new information, but you can look at this and see if you get a biophysical profile that's 8 out of 10 without an NST, or 10 out of 10 with an NST, or 8 out of 10 with normal fluid, you're at the high end of a good positive score and you're probably going to do well. If we go to the other end of the scale and you score 4 out of 10, 2 out of 10, 0 out of 10, your degree of potential for fetal asphyxia is much higher. And in those instances, you're considering delivery. Now, there's been some interesting work on biophysical profiles over the years. A 2008 Cochrane said there's really insufficient evidence from randomized controlled trials to support using it in high-risk pregnancies, but people seem to have always done that. There was further work where they looked at 2017, looked at some trials. I think there were 19 trials in total that they looked at. And they said, look at the Doppler of the umbilical artery, may give you some good prediction of perinatal deaths and may decrease interventions. And a recent meta-analysis in ACOG in 2023 by Ran, who I believe is out of Australia, also looked at it and suggested basically there are some limitations to the biophysical profile, but there's value in looking at some of the blood flows. Basically, as I said, observational studies said that there's lower perinatal morbidity and mortality once you get a good score on your biophysical profile. And the 2 most important features, the amniotic fluid volume and the NST, were developed by some people to look at a modified biophysical profile. But again, you can see that the false negative and false positive rates, both in the biophysical profile and the modified biophysical profile, are significant. And we need to be attentive to these as we look at the value of a biophysical profile overall. One of the things that is extremely important when you're doing antenatal testing is communicating that work. You're communicating it both to your colleagues as well as to the patient involved. You need to transmit any initial findings that you have so people are aware, and letting them know if in fact there's an escalation of concerns. We're doing testing because we're concerned about a risk. Has that risk changed? Is it getting worse? Because they are going to be anxious every time you do a test. It implies to them that there's a concern with their fetus. And we all know that is very critical to individuals who are pregnant. And so communication is key. It's also key that you document that communication, what the conversation was, and how clearly you were able to sort out the situation in terms of a shared decision-making plan of care. So when you document your risk factors, discussion with the patient, what your plan of care is, the results of the assessment and test, and what is your continued or revised plan of care. And one of my favorite slides, I always put it in, which is always to hope that people use correct terminology. We all, within our own units, have slang phrases we use that are perfectly meaningful to all of us who work there 100% of the time. But for the learners coming into the situation or the people coming in briefly, they may have no idea what you're talking about. So using proper terminology is really important. And I just emphasize it with my favorite slide. So take-home messages from this presentation. Antenatal fetal health surveillance should consider the entire clinical picture, as we've emphasized, which includes the patient risk factors, what your local resources are or aren't, and therefore when you need to make a referral. What protocols exist in your region? And it's a helpful thing within your region to have some established protocols to access certain kind of testing. That will make your access to those tests more efficient and transfer of patients when needed easier. Looking at urgency. And always, as I've emphasized, patient preferences with shared decision making. Ensuring that that is an informed discussion and patient preferences are taken into account. The modalities that we use in antenatal fetal health surveillance are assessing that fetus at a single point in time. And as I mentioned, they have a poor predictive value for ongoing fetal well-being. So your concern then becomes, how often do I have to repeat a test? Should I be doing 2 tests instead of just 1? Will that give me a higher rate of understanding of fetal status if I do 2 tests instead of just 1? And additionally, developing clear regional protocols for testing, for consultation, for transfer of care. Who do you call? How do you make that happen? What is your protocol for communication in terms of what must be in writing, what is verbal, all of those kinds of things. Depicting the urgency of a situation. And that urgency may vary with the level of care you provide. If you're in a very rural level 1 facility, your urgency to transfer someone out is obviously going to be higher when the risk factors present than if they're in an advanced level 2 center where they can maybe tolerate that risk for a longer period of time. And obviously, communication, I can't say it often enough. It's there twice for a reason. It's a very important criteria that we need to pay attention to. So that's the end of what I'm going to say. And at this point, certainly any comments, questions, or concerns, I'm open to discussion on those if people would like to. I'm going to stop sharing my screen now so that we can you can see our faces and perhaps have a better opportunity to raise your questions. Chris, I'll turn it over to you now.
Yeah, thank you so much, Sharon. That was a great presentation. I learned something every time I listen to you. Your knowledge is just
thank you.
Deep and wide, much grander than many of ours. Are you up for a couple of questions? You ready?
I'll do my best.
All right. We've got a couple of really good ones here. The first one, as I think you predicted prior to this, and I asked you prior to this, is about the clarification on the no contractions during an NST. So the first question that's come through says the guideline says regular uterine activity. So any contraction, could it be singular? For example, I have a 38-week diabetic patient having weekly NSTs. And if she has one non-painful Braxton Hicks contraction during her 20 minutes of EFM, should I be assessing her using the intrapartum assessment guidelines?
Good question. And thank that person for raising it, because it is a really important feature. One of the things that we really have to assess when we have what appears to be a contraction and a Braxton Hicks contraction, I believe the person defined it as, to what extent is that a stressor versus a real contraction? In other words, how uncomfortable is this? I have seen, this is my other little soapbox I'll just mention here. You see individuals who are having an induction of labor, and we know that people won't increase the oxytocin if there's tachysystole. Well, one of the things in the definition of tachysystole they do not address, which I'm taking on, but they don't address, is intensity. So if I'm sitting there and I'm playing cards with my partner, I'm reading a book, I'm not even aware they're happening. Does that have the same impact as a contraction that I really feel and I know is uncomfortable and I'm aware of occurring? Is the intensity of that uterine muscular contraction down on the blood flow the same as if I have a Braxton Hicks? Probably not. But if there is a contraction that is showing a change in the fetal heart rate, then I would be assessing that contraction or that uterine activity in some degree of detail in terms of frequency. I'd be having a hand on the abdomen to do palpation, because that is the only way to properly assess if in fact you do have intensity. We know that the external fetal heart rate monitor cannot properly assess intensity. So you need hand on there and say, is this a contraction? If it's a contraction and it's really strong and painful and occurs more than once particularly, then that's meaningful. But one Braxton Hicks I don't think counts as sufficient to quantify moving to an interpartum fetal health surveillance criteria. I'm
Good
open to
answer.
comments on that, but those are my thoughts.
I have a small follow-up question on that. Like,
Sure.
is it important to assess cervical change along with the contraction? Like, is that one of the criteria you use to determine whether or not you're dealing with a true uterine contraction versus Braxton Hicks or just uterine activity?
Well, you can. The problem is if someone's a gravida-4, you can have a multi-psoas, which can fool you all the time, unless you have serial cervical assessments in order to look at that. So the dilemma really becomes, yes, if you think you're feeling a contraction, absolutely document the cervical status, absolutely. And does that change over time? If it doesn't, then in that occasional little flip of a contraction is probably not real. You also look at this with, as I say, with intensity and frequency, and always ask the patient, what are you feeling? Is this something that you feel all the time? Has this been going on for 2 weeks and you felt this? Or is this something brand new that you've not felt a discomfort like this before? And as always, in any instance when we have abdominal pain, we think about other causes of abdominal pain. Does she have a UTI? Is there an abruption? Are there other things going on that may be unrelated to the actual uterine mechanism?
Good answer. And I hope that clarifies for the person who asked the question. And if it doesn't, Sharon, I'll just ask you to give a little explanation here. If people have burning questions after this, because I know it will be well watched after it's recorded or once it's released on the website, how should we get additional questions to you?
One of the things that I'm trying to do is I've done this for Kaplan, which is the Canadian Association of Perinatal and Women's Health Nurses. And I'll be doing it again for a group of caregivers in Toronto in a couple of days. And I'm trying to collate all the questions. What I've done is I've created answers to the questions I've received so far, and I've sent it out to the author group of the guideline to make sure we're all in agreement and we're all saying the same things. So if people have additional questions, I'd be most pleased to incorporate it into that document so we have good clarification of any things that are not clear or need further detailed explanations in order for people to move forward. So any questions people have, I'd be thrilled to incorporate it. And as I say, share that wisdom with all the people who are authors on this guideline, not just me, so that we have a collective answer that is consistent across the country.
That's maybe the best answer to how will you answer questions I've ever heard. So thank you. That's as complete as it gets. So to find Sharon, actually, if you want to send questions to me at crokush@connectmlx.com, I'll be sure that Sharon sees them and they get included in the mix. I think I have time to ask you one more. There's an interesting
Sure.
question here that I'm interested in the answer. It says, in the table of classification of the NST, which is found at the end of the guideline, I believe, or in the
It's in there.
references, it's in there
Yes,
somewhere.
I think it's
in the
an
references.
appendix. I think it's an appendix.
There's a question about qualifying the NST as normal if there are non-repetitive, uncomplicated variable decelerations. In a situation where the variable decelerations are occurring with fetal movement, in conjunction with fetal movement versus in conjunction with contractions, what is the path forward?
Okay, let me go. So let me see if I fully understand this question. So what they're talking about is you've got a fetus in there who's having a ballet recital or a soccer game or something, and you're seeing variable decelerations associated with that. Is that the question?
Yes, with movement versus with contractions. You're seeing, so you're maybe not having contractions, but you're seeing fetal heart rate. That's my understanding. Fetal heart rate decelerations with fetal movement plus or minus contractions.
Well, we think about variable decelerations as being caused by compression of the cord. So if the fetus is having some activity in there, it maybe they're jumping on and off the cords. Sometimes these fetuses are crazy little dudes in there that are hip checking the cord into the pelvis or something silly like that. It's odd to me that that would occur regularly. I'd certainly use intrauterine resuscitation measures to reposition the individual to see if that alters things and says, okay, get off the cord, fetus. And if that's helpful. If it is persistent variable decelerations, I would certainly keep that individual on the fetal monitor and see what else is associated. I'd be looking for other causative factors, and it would have to be looked at within the context of gestational age and other perinatal risk factors, comorbidities that may be present at that time. It's unusual to see it with movement, but there's no reason that an occasional one wouldn't happen when you think of the physiology of the principles behind it. But it's not something I would expect routinely to occur. I think I've understood that question, but if I haven't, I'm certainly happy to readdress it if the person wants to resubmit it to you.
Okay, thanks. I feel like you probably answered it, that deceleration would be related to cord compression, which may be, or hopefully is only related to some kind of fetal positioning and could be easily corrected. But if it's repetitive, further testing. Is that correct?
Yeah,
Yeah.
basically.
Okay.
What really is going on is what you're thinking about.
Yeah. Okay. Well, thank you once again, Sharon, for that fabulous presentation. Do you have any final words you'd like to share with us?
No, I think it's all very exciting as we move forward. But as I always say, with every caveat, we've created a guideline, and we all know that there's going to be some research study published about a month after we finalize the guideline. So always stay alert to what is the latest clinical evidence that's available, as well as what's in the guideline. And while the guidelines are updated every 5 years, there's a lot of research that occurs between the time of publication and that 5-year mark. So if there are further keen trials that have come out that are very relevant, it doesn't mean the guideline is anything but a recommendation, not written in stone as new evidence appears.
Mm-hmm. Excellent. Excellent advice there at the end, because things are changing so much every day, it seems.
Oh my goodness, yes.
Well, thank you once again, Sharon. Again, I appreciate it so much for the generous sharing of your time and knowledge. And thank you to all of you for attending. Of course, we'd love to hear from you if you enjoyed this webinar, if you have any feedback, if you have further questions, as we mentioned, or if you have ideas for future webinars. And if you either need a healthcare expert or would like to become one, get in touch anytime. We'd be happy to hear from you again. That's our 60 minutes up. Thank you again. Goodbye and take good care.